All right, we will go ahead and get started this evening. Good evening, everyone. Welcome to Aspira Women's Health Key Opinion Leader webinar entitled Ovarian Cancer Risk Assessments Utilizing Multivariant Index Assay. My name is Victoria Haverbush. I'm Aspira's Director of Portfolio Development, and I'll be your MC this evening. One note that this webinar is being recorded. One goal this evening is to share some details and data regarding our OvaSuite portfolio. This includes both OvaOne Plus, which many of you may be familiar with, and OvaWatch, which is a newly launched product as of December 1st, 2022. With the addition of OvaWatch, Aspira Women's Health now offers an ovarian cancer risk assessment test for any woman with an adnexal mass. Joining me this evening are two leaders from Aspira, Dr. Ryan Phan, Aspira's Chief Operating Officer and Chief Scientific Officer, and Dr. Leo Twiggs, a gynecologic oncologist and Aspira's Director of Medical Affairs. We're also joined by two esteemed clinicians, Dr. Gerard Reilly of Axia Women's Health and Dr. Tamika Sea of Advanced Women's Care Center. I'll have each speaker introduce themselves and their background as they begin their respective sections. With that, I will hand it over to Dr. Ryan Phan.
Good evening, everyone. Thank you for joining Aspira Women's Health webinar. This is our last webinar of 2022, and it's our honor to have you join in our discussion tonight. So the topic of our discussion tonight is ovarian cancer risk assessment utilizing multivariate index assay. Next slide, please. So for this discussion, as Victoria already mentioned, we will moving forward with the two key products of Aspira Women's Health, assessing the risk of ovarian cancer. Next slide, please. Joining me tonight with the panel of the three clinicians that Victoria already mentioned, we'll dip into detail of our discussion, starting with Dr. Leo Twiggs, who is a Aspira Director of Medical Affairs, who will be discussing the overview of ovarian cancer care as the current standard practice and how that related to risk assessment of ovarian cancer. In addition, we also have Dr. Reilly, who is the Director of Clinical Research and Innovation of Axia Women's Health. Dr. Reilly will discuss the most recently launched product of Aspira called OvaWatch, a non-invasive multivariate index assay that may benefit women with adnexal mass, evaluated by initial clinical assessment as indeterminate or benign. And last but not least, we also have Dr. Tamika Sea, who is a gynecologist at Advanced Women's Care Center in Georgia, who will discuss how Aspira's OvaOne Plus test lead to improved health outcome for women with adnexal mass, particularly for the patient who plan for surgery. So with that, next slide, please. I want to give probably a couple of minutes to discuss about Aspira Women's Health. So we are the company that devote and transform women's gynecologic health, starting with the ovarian cancer. The company has been in the market and leading the way development of gynecological testing technology for more than 20 years. We are world-class, involved with world-class academic and medical institutions throughout the process of development of multiple assay to assess the risk of ovarian cancer, and you will hear in a minute later on. And one of the leading products that we have in the market right now called OvaSuite. OvaSuite product is composed of two main products. One of them is OvaOne Plus, and the other one is OvaWatch. OvaOne Plus is a combination of two FDA-approved assays for women planned for surgery. OvaWatch, I'm very happy to announce to you that we just recently launched in December 1st, 2022, and OvaWatch an assay that's spanning a patient population to all women with an adnexal mass. In this process, we are the only company in the market that have a non-invasive test that provide assessment for ovarian cancer from the beginning with adnexal mass, both non-planned for surgery as well as planned for surgery. We are in the process of developing additional blood tests for identification of endometriosis, planning launching in 2023. Our products are distributed by a team of dedicated commercial professionals throughout United States as well with our partnership at BioReference Laboratories. Next slide, please. So two products that established are OvaSuite, it called Over 1+. As mentioned, Over 1+ is intended use for women with an axial mass planned for surgery. In addition, the most recently launched product, OverWatch. OverWatch is a non-invasive assay that is serum-based biomarker where we discussed it in detail with Dr. Reilly, that intended for women with axial mass that either initially evaluated by indeterminate or benign. For this OverWatch, we expand the population of women with axial mass based on the current calculation in the United States between 1.2 to 1.5 million women. Next slide, please. So for now, I would like to turn the floor over to Dr. Leo Twiggs, who's going to give an overview of ovarian cancer care. Dr. Twiggs.
Thank you, Dr. Phan. It was good to hear our overview about our company, how important our company is actually investing in diagnostics for patients with an axial mass, but importantly, an axial mass is oftentimes the harbinger of ovarian cancer. And that is one of the problems when you look at the overview of ovarian cancer care. The problem is that we're not as good as we like to be, and we don't have a good screening test for ovarian cancer yet. So we need to be even more diligent with our diagnostic acumen. Next slide. So again, the standard of care for assessing a risk of ovarian cancer can boil down to kind of three different ways. Obviously, the clinical assessment is the physical exam and the ultrasound you perform in your offices, oftentimes with patients with symptomatology, abdominal pain, fullness, and so forth. These are subjective tests, and they do rely on our judgment, our physician and provider judgment, and the technical expertise of the ultrasound and how it's done in your particular practice, whether it's done in the office, done in the radiologist's office, and so forth. There are blood tumor markers that have been used. The CA-125 over the last almost 20 years now has been used off-label in symptomatic patients, and we'll show you today how inefficient it really is. There is an alternative Roma test, which we have compared our tests to, and ours is somewhat better, but they have limitations of low sensitivity and high false negatives, especially in the premenopause and early stage patients. And again, the tissue analysis, which is good if you're dealing with a lymphoma or a lymph node abnormality, but preoperative biopsies are often contraindicated because of the possibility of procedure-related tumor spread. So there's really an unmet need and room for improvement for diagnostic tests in patients who present with an axial mass. Next slide. So we look at ovarian cancer. The bottom line here is that the diagnosed in late stage 65% of the time. So obviously the problem we face is that the preclinical phase of ovarian cancer may be relatively short, maybe less than 6 months. So if we compare it to cervix cancer, which takes 3, 4, 5, maybe that long to develop, we only have a short time frame to find the cancer in its preclinical and curable phase. Cervix cancer, for example, we can do screening over time, and again, the slow preclinical phase of cervix cancer makes it more amenable to early diagnosis. So that is one of the problems, and that's one of the reasons we've developed these tests to try to help the clinician and the patient decide exactly what the risks are when an axial mass presents. Obviously, we'd like to see all our patients in stage 1 with local disease with 5-year survival of 92%. And again, the incidence is relatively small when that happens. So again, this is the devastating truth of dealing with patients with an axial mass. And most of the time, an axial masses aren't cancer, but we have tests that can help you decide what exactly to do with the patient. Next slide. So when a pelvic mass is detected in ultrasound, there's 3 different categories that we can put the patient in. Obviously, on the one on the right, the clearly malignant doesn't, when the when the CA125 is elevated and we can refer it and our tests are positive, you can send it to the patient to the GYN oncologist for evaluation, present of ascites and so forth. That's relatively simple clinical. When it's clearly benign and there's very, very clear ultrasound criteria, which will guide you for watchful waiting management symptoms. The problem is when it's indeterminate, and when we really can't say it's clearly benign or clearly malignant. This is where our company has the test to help you decide what to do with the particular patient. Again, the indeterminate clinical situation oftentimes is, are they planned for surgery or they're not planned for surgery? Obviously, we have say a 32-year-old patient with an exomass who's contemplating fertility. Obviously, we don't want to do surgery unless it's absolutely necessary. So again, that's where our tests will come in, and our doctors today will give you precise indications for the use of these tests in the indeterminate clinical arena. Next slide. The serum biomarker performance, we can look at it here. And I think the quote at the bottom is probably the most important. Despite our clinical reliance on CA125, its utility is limited because of low sensitivity for predicting cancers in premenopausal and early stage patients. So when we look at the sensitivity of our various tests, the OVA, the Overa, the OVA1, the Roma, and the CA125, you can see that our tests perform better, and especially with premenopausal patients. And so we think that by using Overa or OVA1 in our new tests, OVA Watch, in a patient who is not planned for surgery, we can give you the kind of risk assessment that helps you and your patient make the right clinical decision at the moment. Next slide. So I'm happy to introduce my colleague, Dr. Sea, who has lots of experience operating on adnexal masses as a benign gynecologist, and she's going to talk to us about the OVA1 plus clinical application. Dr. Sea?
Thank you so much, Dr. Twiggs. Hello, everyone. My name is Dr. Tamika Sea. I'm a practicing OBGYN here in the Metro Atlanta area. I'm the founder and owner of Advanced Women's Care Center. I'm a full-service OBGYN practice here in Stockbridge, Georgia, roughly about 30 minutes outside of the city. And I'm here to discuss with you this evening the clinical application of OVA1 Plus in your offices. Next slide, please. So with any patient that we are planning surgical interventions for, a transvaginal ultrasound is usually performed in order to gain more information regarding the pathology that we're surgically intervening for. This can include all sorts of pathology, of course, whether it's previously diagnosed or incidentally noted. Plenty of us have done an ultrasound and found something that we weren't expecting. And this modality is used to evaluate the evidence, and investigate ovarian lesions as to whether or not they exhibit any forms of characteristics that raise concern for possible malignancy. The American College of OBGYN has published a multitude of guidelines regarding the usage of serum markers in conjunction with imaging to assess whether or not there is a concern for malignancy in patients prior to going to the operating room. And the multivariate index assays OVA1 and Overa, both FDA approved, are indicated to assess for this risk in patients that are already scheduled for surgical management. So the big take home with OVA1, Overa, and OVA1 Plus, which is the combination of the two, these are going to be clinical tools that you utilize for those patients that you already have slotted for surgical management. And OVA1 Plus combines OVA1 with reflex to Overa to decrease false positive rates and increase the positive predictive values for assessing for potential for ovarian malignancy. Next slide, please. So as we stated, OVA1 Plus is a reflex process that combines OVA1, which is the original first generation multivariate index assay, which checks for the 5 serum biomarkers, and Overa, which is the second generation MIA screening tool that adds HE4 and FSH to the biomarker screening index. So for instance, if you have Ms. Smith and she has this ovarian mass and you decide to perform OVA1, prior to taking the patient back for surgery. Let's say she's menopausal and the OVA1 test is performed and she has a low risk assessment. Then you will receive a laboratory report sheet interpreted in the OVA1 scoring system. But let's say she comes in with an intermediate risk, like Dr. Twiggs discussed in his previous presentation. Then this is where the power of Overa is really seen. The OVA1 will then reflex to an Overa screening, and your laboratory report sheet will be interpreted in an Overa scoring system. And if there's an elevated risk, then the report will once again be interpreted in the OVA1 scoring system, and an Overa will not be performed at that time. As we can see down at the bottom left, we have the reference ranges for what are considered low risk, intermediate risk, and elevated risk categories for these patients. And these are the scoring systems that you'll note on your laboratory report sheet when you get your information back on your patient. On the bottom right, we illustrate the sensitivity and specificity of the screening tools with OVA1, Ovarian, and OVA1 Plus, of course, which is the combined reflex study of the two. And it has a pretty great sensitivity, but the specificity increases with the usage of OVA1 Plus, further decreasing those false positive rates and aiding in the detection of potential malignancy, especially in our premenopausal patients. Next slide, please. As stated, OVA1 Plus decreases those false positive rates, and this allows for patients to be managed appropriately, either by their general gynecologist or a GYN oncologist if necessary. But this allows for there to be a decrease in referring of these benign lesions to our oncology colleagues, who we really want them focused on actual malignancies versus seeing a slew of patients on their schedules and in their clinics that likely have benign pathology. Also, this really helps with patient satisfaction and morale. Patients are definitely going to be happier if they don't get troubling news about going to an oncologist, especially with a high likelihood of them having benign disease. Also, the mere travel to the consultation may be cumbersome for patients. For instance, in my institution, we don't have a GYN oncologist on staff, and our oncology patients usually are sent to our main campus in Atlanta in our hospital system. As stated, I'm in Stockbridge, so I'm roughly about 30 plus minutes away from the main campus where the GYN oncologists are available. So this is just more of a cumbersome situation for your patients, especially if there's a high likelihood that there's benign disease that's present. So performing this clinical tool and assessing the risk for likely benign disease is so important to the patient overall. Also, OVA1 has the ability to detect malignancy even when CA125 is normal or non-diagnostic, and this is a very important take-home in regards to the testing that we provide. And here we have two articles published by Dr. Charles Dunton, who's a renowned GYN oncologist in the Philadelphia area, illustrating these facts. Next slide. So this slide illustrates the superiority of OVA1's performance in detecting ovarian malignancy, even when CA125 is not clinically elevated or just non-diagnostic in general. And this is very important in your premenopausal patients specifically, who already have a diagnostic tool like CA125, which has a low predictive value for them and concerns for missing an early onset ovarian malignancy in that patient population. As we see here, we still have a sensitivity above 50% in detecting the malignancy across all categories of women, but very important that we still garner a 51.28% sensitivity in our premenopausal patients, even when CA125 was in the normal range for these patients. And this is very pivotal and gives OVA1 a leg up in the race when detecting possible malignancy, even when our mainstay serum biomarker CA125 doesn't give us enough information. Next slide, please. And this is a perfect segue into a discussion it's a very intriguing topic regarding ethnic disparity in the diagnosis of ovarian cancer and how it relates to the usage of CA125. As we may know, African American women actually overall have a low incidence of ovarian cancer in relation to other ethnic populations. However, they are disproportionately affected by high-grade and aggressive ovarian cancer lesions. African American women tend to have lower survival rates. They have higher rates for recurrence. And of course, there are a number of confounders that cause this data to be fact, right? So of course, there's healthcare access issues, socioeconomic status, other at-risk comorbidities that overall increase that patient population's risk for ovarian cancer in general. However, new data suggests that CA-125 alone as a biomarker screening is not predictive for malignant disease in African American women, solely because the expression of CA-125 biomarker itself is decreased in that population. So here we have a screening tool that we've used for ovarian cancer, like Dr. Twiggs said, for at least 2 to 3 decades, and we're utilizing it in this at-risk population with a known history for aggressive disease, when in fact CA-125 is less expressed in the population in general. So as we see here with the data illustrated, the usage of CA-125 using the standard ACOG cutoff in Caucasian women has a sensitivity of about 74.4%, which is pretty good. But if you look at that same chart and you utilize the same cutoff in the African American population, and it only shows a sensitivity of 33.3% in the detection of malignancy, and that's pretty astounding. That it's such a decline in the ability to denote ovarian malignancy in the African American population. Now you compare this data with the usage of a multivariate index assay such as OVA1 or Overa, we can see an increase in sensitivity for the African American group, increased to 79.2%, which is fantastic. I mean, here we are, going from 33.3% to 79.2%. This is definitely a clinical tool that you want to have access to in your offices, simply because A, it outperforms CA-125 alone, but especially in your African American patients who already have such an arduous trek with ovarian cancer screening, diagnosis, treatment. This is something that you definitely want to make sure that you have available to those patients. And the earlier we get those patients into an oncologist for management, the better. Next slide, please. And here we have a depiction of the laboratory data report when you perform an OVA1 screening for your patient prior to taking them back to the operating room. As you can see, all of the patient's demographic information is at the top, including the patient's menopausal status and whether the ultrasound was performed. It also will tell you whether or not if the ultrasound had a low risk versus a high risk ultrasound, and that's not pictured on the report, but there is information regarding the severity of the ultrasound that will be included in the laboratory report. As we've stated previously, if you have a patient that falls into an intermediate risk OVA1, you will have a reflex Overa screening performed, and the test results will be interpreted in the Overa scoring system. And as we see here, this patient received an elevated risk for Overa with a 6.7, and this is a patient that you would send to your oncology colleagues for further evaluation and treatment. You also receive the CA-125 results, and as you can see here, this patient actually had a normal CA-125, but actually was stratified into the elevated risk once Overa was utilized, which is very important. Next slide, please. And this is just a close-up of the malignancy risk for this patient, and this is the information that your patient wants from you as a clinician. Doc, I understand I have this ovarian mass and you perform this test and you're saying that I have an elevated risk. What does that mean for me? What does that mean for my overall risk factor for ovarian cancer? And what you want to quote them is that risk for malignancy percentage, which is individual per the patient. For this patient, if she had a low risk ultrasound, it was menopausal, then her risk would roughly be about 20%, which is, I mean, still pretty high, and likely will warrant a GYN oncology consultation in my practice, especially. But if she indeed had a high risk ultrasound, let's say the size of the mass was concerning, they saw excrescences, they noted multiple septations, they noted papillations, all of those, clinical symptoms that clinical signs that we see on ultrasound as concerning characteristics, then this patient roughly has a 50% chance of this mass being malignant, which definitely warrants a GYN oncology consultation. And now you have triaged the patient to the appropriate surgeon for the surgery. And the patient, of course, will definitely appreciate being placed in the right hands at the right time. Next slide, please. All right, we will have Dr. Reilly speak about the clinical development and validation of OvaWatch. Dr. Reilly?
Thank you, Dr. C. That was a nice presentation of the value and the utility of the OVA1 and the entire pathway. I get the fun job tonight to tell you about a new test, something that my research center here in Cincinnati, home of the Cincinnati Bengals, was instrumental in doing some of the initial background work and providing samples as the test was developed. And then we also were the first center in the country to start using OvaWatch, and I already gotten feedback from some patients and making some clinical decisions based on the results of that test. So have some exciting news for you here tonight. And looking back at my career, so I was a full-time OB-GYN for 30 years, and then last year stopped doing deliveries to expand my research projects. Still do a lot of GYN surgery and office gynecology, and I like doing my own surgeries. I like taking care of my own patients. Our patients would rather come to my office and have me do the surgery if that's appropriate. But if there's a higher risk of malignancy and it's something that we need to refer on to the GYN oncologist, we want to make that appropriate referral for the best care for the patients and for the best prognosis. But this is a new tool that can help you to decide about the timing of the surgery, whereas OvaOne is helping you with the decision of who should do the surgery. Next slide. So this is a new test that is worked on to help you decide for the patient who maybe doesn't want to have surgery right now. I myself have 6 children, and 5 of them are daughters, and they're all early on in their professional lives, whether that be in graduate school or starting new careers. And if something were to come up that they were told they needed to have a surgery, the question is, how important is it to do that surgery at this time? Is there a chance that mass could go away on its own? And in the past, ever since I was in medical school, we were relying on CA 125, even though we were told, especially in those premenopausal women, that is not where the test was validated. It's not FDA approved for that. And yet we had no other tools. And now for the first time in my career, we actually have a tool that's validated for making those true clinical decisions on whether it's safe to wait to do someone's surgery or maybe not do the surgery at all, or if someone does need surgery, what's the best surgery and who is the best person to do that surgery. So the reality of it is, this is a better risk assessment for patients who don't want to do surgery at the current time, or the patient doesn't want to do surgery at this time. Next slide. So it really does expand the group of patients that are able to be managed appropriately by the generalist. And in reality, I think some clinicians were using OvaOne Plus to decide about surgery as a substitute for the CA125. And in reality, that is not how it was designed. It was designed for the potential for malignancy, not for a negative predictive value. So the goal of the OvaWatch development and the goal of this project was to develop a different type of multivariant assay that could truly assess the negative predictive value and the safety of waiting to do a surgery. Next slide. So this is the publication that we had earlier in the summer, which was the validation of the OvaWatch algorithm. And I think it's important for everyone to understand that OvaOne is looking at 5 different biomarkers. OvaWatch is looking at 7, and also including the patient's age and their menopausal status. But it's not just combining those 7 biomarkers to give a different score. The idea of a deep neural network and machine thinking is that the computer weights the different scores and different methods to maximize the negative predictive value. And that's really the biggest difference between OvaWatch and that algorithm and multivariant assay as compared to using the OvaOne, or some centers will have their own mix of the CA125 with maybe the HE4 or some other markers to determine their gut feeling for malignant potential and whether this patient can wait to have surgery or who should do the surgery. But in reality, those are not validated. There's not statistics and studies to support that decision making. But up until this time, that was the only option that we had. And the reality of it is, less than 20% of those masses are going to end up being malignant, especially for the patients that are premenopausal. So the ability to have a better assay that can help us decide about the malignant potential or the confirm the benign characteristics of the mass is something that I think we've all been waiting for. Next slide. So this slide is a little bit busy, but basically it's the way that the OvaWatch test was initially developed. So it was developed over here to the left where it says the training set. So the training set was about 850 patients with 280 of them with a known malignancy and 570 were benign. And that was where the model was built. And this deep neural network was used in the machine thinking for the computer to weight the different scores to be sure that if something was benign, it was identified as being benign. And then if it was malignant, to make sure it still had a reasonable sensitivity and specificity. So once the device and the algorithm was developed, then it was validated by looking at a larger set. So there's companies out there that will have these serum banks, so you can purchase the serum bank. So they looked at 2,000 samples to validate the test. And of the 2,000, only 98 had ovarian cancer, so mimicking about a 5% incidence in the group of patients with adnexal masses, and over 1,900 were benign. And they were blinded to the investigators and to the algorithm, and were able to completely outperform the CA-125 and the other biomarkers that are on the market today with that very, very strong negative predictive value of over 99%. So this was how it was developed. But again, I want to emphasize that it wasn't just adding more biomarkers, it's the weighting of the biomarkers through this system that gives it such a high negative predictive value. Next slide. So this slide is fairly busy, but down there in the lower right corner, you can see the negative predictive value both for premenopausal and postmenopausal women is well over 99%, and in premenopausal, 99.54%. So for that younger patient who has a mass with somewhat concerning characteristics, if you have a negative OvaWatch, you can be very confident to wait to do that surgery or perhaps to delay the surgery completely to see if the cyst might resolve on its own. Next slide. So again, this is the report, and the report is very similar to the OVA1 and the Ovarian report in that it's still scored from 0 to 10, with the lower scores being low probability malignancy, then there's intermediate, and then there's high risk. And this will be weighted based on the patient's age and menopausal state to tell you what is the negative predictive value for that age group. Next slide, I think it zooms in a little bit better. And you can see the negative predictive value for this patient was over 99.5% with a low score. So even if the mass looked concerning, if this is someone that you wanted to wait or delay or avoid the surgery altogether, it would be safe to do that from a malignancy standpoint, assuming that the patient was asymptomatic. If you do like still following the CA-125 and the HE4, if that's what you're used to, that is also reported, and the normal ranges are reported in the OvaWatch report. Next slide. So I think this is a typical day at my office, at least, that a patient presents and says, I just haven't really been feeling like myself for the last couple of months, and I was looking on the internet, and according to Dr. Google, there's lots of different things it could be. It could be my bowels, it could be my bladder, but they also mentioned ovarian cancer, and sometimes are concerned by the most serious of possibilities when they have some of these more vague symptoms versus the most common diagnoses that it could be. So the patient comes in, her exam seems fairly unremarkable, but she is still concerned about these symptoms. So you go ahead and order an ultrasound and get some blood work, and patient goes home, talks to more friends. By the time she comes in for ultrasound, she's even more worked up and has a couple other opinions, both on the internet and from her friends. And sure enough, an ultrasound, she comes back with a 6-centimeter mass, and it has a couple septums and a few concerning signs along with that on the ultrasound. But the OvaWatch is ordered, and the OvaWatch comes back negative with a negative predictive value of over 99%. And so the patient is now relieved and is confident with waiting and not proceeding with surgery. And the doctor is also confident with that decision. So certainly there's times that patients want to have surgery and you have to tell them why you don't think they're a good surgical candidate. But then when the patient doesn't want to have surgery and you agree with them, you want to be sure that you're confident with that decision, not that just you're agreeing with the patient, but that it's the right medical decision as well. And the OvaWatch gives you that confidence. So anything I don't like about this pathway is then it says 4 years later, the patient presents with more symptoms. Well, certainly I think any of us with a patient who has a 6 centimeter mass isn't going to go 4 years without seeing the patient or at least following up with another ultrasound. But let's just leave it that the patient was fairly asymptomatic and the cyst wasn't getting significantly larger. And then 4 years later, her pain started to get worse. And she said, you know, the cyst isn't going away, it's bigger. I think I want to go ahead and have the surgery done. And on ultrasound, the mass is a little bit larger, but doesn't look overly malignant. The OVA1 plus comes back as low risk. So then she can stay at my office and I can do her surgery instead of having to send her over to Dr. Twiggs' office and filling up his office with benign cases when his skills and experience should be reserved for the patients with more malignant potential and more serious conditions. So I think it's a fairly common pathway there, and it's great to be able to have these tools to help you decide, do you need to do surgery? And if you're going to do surgery, who's the right person to do the surgery? Next slide. So when I give this talk to the residents, it's, you know, these are the kind of questions you'd want to have on your board exam, right? So on the left side of this slide, pretty clearly a benign cyst, even though it's fairly large, if it's less than 10 centimeters, clear with some thin septums, most of us would be confident in calling that a benign cyst. And on the right, certainly looks very concerning for malignancy. So I think those two extremes, the testing still is beneficial, but in reality, with the more extreme examples on ultrasound, the decision is hard to make. But the harder decisions to make is that large mass that has some echoes inside, doesn't look quite like a benign cyst, but also doesn't have too many worrisome characteristics for ovarian cancer, that it may be a atypical endometrioma, it could be a dermoid with some internal echoes with some cartilage or some bone on the inside, it could be a thecoma or other solid ovarian masses that are not malignant, but still have a concerning appearance. So this is where the ability to add in the OvaWatch to decide, is this a surgery that needs to be performed? And then you can follow up with the OVA1 to see who does the surgery. Or if the OvaWatch comes back with that very high negative predictive value and the patient wants to watch to see if the mass will resolve, then it would be safe to wait and see what happens. Next slide. So before I go on to Dr. Phan, I did want to share some of my personal experience. So as one of the lead centers for the development of the OvaWatch, we're the first clinic in the country to actually start using it on our patients. So we have had 3 patients that we've used with the OvaWatch since it was released here in the fall, and now across the country being released December 1st. And all 3 of them are older patients. One of them we've been watching for a few years. She was actually in the original OvaWatch study when we were developing the test, and her cyst has continued to get a little bit larger, and now she's starting to get a bit symptomatic. And in October, she was wondering whether she needed to have surgery, but she had a vacation planned and also was heading into Thanksgiving and Christmas. So we ordered the actual OvaWatch test through Aspira, through our early release program, and her level came back as a 1.1. So it was safe to watch her through the holidays. Saw her for a pre-op visit yesterday, and then she's going to have her surgery in January after the holidays are over, because she is somewhat symptomatic. But in reality, the high negative predictive value, even for someone in her 70s, made us confident that we could wait until after the first of the year. And then the same thing for another patient who has a kind of a concerning looking cyst with multiple septums and one solid component. And again, it may be an atypical dermoid that just hadn't been picked up until she was in her 50s, and her level is less than 3, And she at this time actually wants to delay and hold off on the surgery altogether. And then one of my other partners had a older patient in her 70s, same thing, complex mass that was slowly getting bigger, and her OvaWatch came back as intermediate. So we actually sent off OVA1 on her today, and then based on that result, most likely she'll be meeting with the oncologist if it comes back in the intermediate or high range so that they could do the surgery, or otherwise she'll follow up with someone within our group. So I just kind of wanted to share that as we're getting some real world experience now that it is commercially available across the country. And I think Dr. Phan had some concluding remarks.
Thank you, Dr. Reilly. That's really fascinating. You know, we are so glad that right now, really exciting time at Aspira. We receive a multiple order from OvaWatch in a very short time that the OvaWatch been ordered. And like you mentioned, that is exactly what OvaWatch intended for. And next slide, please. So to conclude it, you know, I just want to remind the audience that why Aspira are focusing on ovarian cancer. Can you go next, please? So in the United States, the cancer for ovarian cancer is about 20,000 a year that have been identified. However, the number of women with an actual mass undergo surgery between 300 to 400,000 a year. And more than that, the number of women being diagnosed with an actual mass is between 1.2 to 1.5 million. So there's a large number of women being taken care of and assessed for the risk of ovarian cancer. And we at Aspira have a mission to how to supporting this process. And go next slide, please. And as you hear today, Aspira is the only clinical lab that provide this clinical assessment with a high negative predictive value starting with OvaWatch, where the intended yield for this assay is for women with an actual mass, initially evaluated by clinician as indeterminate or benign. So for this process, the OvaWatch will provide the result for the patient, either low probability of malignancy, where the patient can be continued to be monitored, or result in indeterminate. Indeterminate doesn't mean that the patient has malignancy, but it provides the clinician a chance to either provide additional clinical assessment or order additional tests, and even consider for surgery, as Dr. Reilly mentioned in one of the cases that early on today. And we also have an OVA1 Plus, which is a combine of two FDA-approved OVA1 and Ovarian, where intended yield for a woman with an actual mass planned for surgery. So we are the only company that have a complete clinical assay that provide a risk assessment for ovarian cancer and high spectrum from the time the woman been diagnosed with an actual mass all the way to the one planned for surgery. So next slide, please. So now I'm open the floor for question and thank you all three clinicians to joining us today to provide additional information. I want to bring them back to ready to answer any question that the audience may have.
Thank you, Dr. Phan. I'd like to request all of our panelists come back on video for our Q&A session. So for our audience, you may feel free to enter your questions in the questions section of the GoToWebinar ribbon. But to get us started and give everyone a chance to enter their questions, I have a question for Dr. Sea. So Dr. Sea, you clearly have experience utilizing OVA1 Plus in your practice, and would wonder if you could describe how using this test has helped you as a clinician. Do you have any particular case to discuss that showed the value of the test of OVA1 Plus, or what relief it might have provided to your patient?
Absolutely, Victoria. So I had a patient roughly about 2 months ago who presented to the ER with actual right lower quadrant pain, had a CT scan that was performed and shown that she had acute appendicitis, and then she had a 4.6 centimeter mass that was on her left. She was 52 years old, menopausal, previous history of a hysterectomy that I did years prior. And she, of course, met with the surgeon. She had laparoscopic appendectomy performed. the ovarian mass at that time. He felt like it didn't look suspicious. He didn't touch it. He didn't give me a call. Just told me to, told her to follow up with me once she was out of her immediate post-op time frame. So because of her age range, because of the fact that we repeated another ultrasound, it looked a little interesting. It had some thicker septations, had some daughter cysts associated with it. It was not overall a benign appearing mass. It has some increase in vascularity. So I discussed with her about the fact that we likely probably needed to think about a surgical intervention for her soon. And I performed an OVA1 for her, and sure enough, it actually came back as an elevated risk. She was triaged to a GYN oncologist in the community. So she just got her surgery done last week, and she's doing well. Waiting on pathology.
Thank you so much, Dr. Sea.
Absolutely.
I have a question for Dr. Twiggs. So with the launch of OvaWatch, as a gynecologic oncologist, how do you think this test will impact clinical practice?
Well, I think that the test can have a lot of utility, especially in those clinicians and providers who are not totally familiar with ovarian cancer and its all its presentations, but they are familiar with the ultrasound and assessing the anexa. And again, when they get the indeterminate ultrasound test, or if they get a test that says that it's benign, the patient's anxious and maybe anxious about surgery, maybe she wants surgery, maybe she doesn't. But again, the anxiety level will be high. If the clinician makes a judgment that surgery is probably not indicated at the moment, it's not planned, the word we use is planned, then the OvaWatch would give that particular person a way of saying, okay, I don't think you need surgery now, but if we did this test, it's got a high negative predictive value. But what does that mean for you? That means that the chance of there being ovarian cancer there is very small. And if you have a patient who is anxious about these kinds of things, I think give us some freedom to allay their fears, and also for you to reevaluate the patient in a period of time to decide what needs to be done in the future. So I think that's what the OvaWatch is going to come into view. I think that's when it's going to be used, and I think that again, when we have clinicians who are focused on the patient's anxiety and understanding a little bit about what they're going through. Again, the Dr. Google reference, they're much more anxious about what's going on than you think. And I think this is a test that could help allay their fears and put you in a particularly good position for reevaluation of the patient in the future.
Thank you, Dr. Twiggs. I know that we're all certainly very excited about the launch of OvaWatch, and certainly would love to hear from Dr. Reilly, Dr. Phan, but really any of our panelists about what you're most excited about regarding OvaWatch being launched and available to the country at large.
I can give a little bit perspective from the Aspira and the scientific process, and then transfer to Dr. Reilly for the clinical perspective of it. So for us at Aspira, have been long consider, we are looking for a very small population of about 20,000 ovarian cancer women a year in the United States. However, there's a significant number of women with an actual mass being identified, and interestingly, up to 30 to 35%. Majority of these actual mass were identified by ultrasound, and interestingly, up to 30 to 35% of those cases are considered indeterminate by imaging. So it gives the clinician into the very difficult situation, what to do with this patient, whether we should go additional process, and currently there's no good marker for this process, particularly of CA195. You hear from Dr. C earlier today. It's not a marker for that process. So as a team of Aspira, and we're working with clinicians across the country, as Dr. Reilly is one of the early and leading center for this process of development of OvaWatch. We've been only consider how do we can help these patients, the patient who have not really planning for surgery, but it's not clear cut of what we're gonna do with next. Are we waiting for this patient where we give them a peace of mind that Dr. Twiggs just mentioned? Excuse me. So that is the reason and that sort of unmet medical need that the team at Aspira are looking for how to develop this test. So we truly believe that they're not just about the science of it, but also, this will be a very tremendously helpful for women across the country and supporting the physician to make the informed decision when they really need it. And that's what we are looking for. And we believe that based on we just launching since December 1st, we enthusiastically adopted by many physicians for their patients across the country. And we think that they will be one of the tools that I talk with many clinicians around the US, and they've been waiting for a while because there's no such thing available to support physicians for this care for their patient. Dr. Reilly?
Right, I would agree. And I think that's what's unique about this test. Is this something that has not been available? And, for years we have relied on CA-125 only because it was the only test that was out there. And the younger the patient, the less reliable the CA-125 is, and also the lower the incidence of ovarian cancer. But for that 42-year-old who happens to have ovarian cancer, if there's something there that lets you know this is one that really needs to be evaluated as soon as possible and taken out of there, then I think that eliminates that level of indecision for the gynecologist and also the level of stress for the patients, because, as we're heading into December here and, come January, everybody's going to have deductibles again. And as soon as you tell somebody they need surgery, they're like, oh, I just signed up for this new plan. It's going to cost me $8,000 or $5,000. I don't have that money. Is there any way I could wait and have it in the summer? Or I don't have any time left off of work because I just went on a trip over the holidays. So you see the stress that brings out in different groups of patients when you tell them they need a surgery. And no one wants that surgery, but I think timing of surgery for many individuals, as such a high percent of women now are working and working at high level jobs, they can't just take off work at any moment's notice without covering their bases at work. And I will say for most women also at home. And as much as you want things to be equal, there's still a higher percent of women who take on the responsibilities of the home life as well as having a professional career. And it takes time to get things in place for the proper care of their duties at work and also their families at home. So if you combine that with, like I said, heading into the high deductible time, if you can confidently tell someone, yes, it's safe to wait 3 months, 6 months, maybe next year, unless you're having significant symptoms. Certainly you don't want to put somebody at increased risk for having a torsion or, having a problem with a markedly enlarged ovary, but certainly many of those may resolve on their own. And I don't like the term unnecessary surgery. I like when Dr. Twiggs says, not planned for surgery, because unnecessary surgery makes it sound like people are doing surgery that patients don't need. But I think it's more a matter of, do they need it based on symptoms? Do they need it based on the malignant potential? And this is just a great tool to have to help you make that decision confidently, that has scientific statistics behind it to support your decision making, that you can help patients to understand, versus in the past we used the CA-125, maybe the HE4, maybe LDH, some basic things that, oh, that's what my professor in med school told me, or that's what the oncologist in our community likes to use. But there's not any statistics behind that to support your decision making if you were to miss something or to do a surgery on someone who maybe doesn't need it. So I think to have the scientific backing behind it makes it a very powerful tool.
Thank you both. We have two great questions in the chat that I'd like to make sure we get to. So the first one, between both providers, how many, and I believe this is directed at Dr. Sea and Dr. Reilly, between both providers, how many patients have benefited from OVA1 Plus and or OvaWatch? I remember hearing Dr. Sea speak on an appendicitis patient back in the November webinar. Have there been any other cases? And I would go so far as to ask, now that OvaWatch is live, do you see perhaps utilizing tests like this more?
Well, from my standpoint, go ahead, Tamika.
No, you're fine. Currently, right now, thankfully, I haven't had any additional patients that have had concerning ultrasound findings that are suspicious for, possible ovarian malignancy that I've had to utilize over one or over one plus recently since the November webinar. And that is the same patient that I discussed just a couple minutes ago. So right now, not, but I'm so excited about the launch of Overwatch because, of course, like Dr. Phan said, I mean, we have these 1.2 to 1.5 million patients with adnexal masses where we really don't know what to do with those patients. We don't have anything clinical. We don't have anything backing us as far as literature and research that can kind of give us some type of clinical tool that we can assess those patients and stratify them into a low risk category that don't need surgical intervention versus a higher risk category that may need surgical intervention or possible consultation with GYN oncology colleagues. So I'm very excited about Overwatch and utilizing Overwatch in the office because I'm pretty positive there'll be quite a few patients that would fit the mold for the usage of the clinical tool.
And from my standpoint, I discussed the 3 patients I've had with Overwatch, and the only reason I have those is because we got early release of the product in November. So I don't think anybody else is going to have a whole lot of examples of Overwatch, but of the 3 we sent, 2 were reassuring and 1, was referred on. And then from a OVA1 standpoint, really in this part of the country, it was not a very frequently used test. And I think many clinicians were looking for more experience, more backing, and a better understanding. And I think now patients and physicians can understand that the Overwatch is kind of the triage test to see, does this patient need surgery or not? And if the ultrasound is also concerning enough that you want to proceed on to the OVA1, then that would tell you, or the OVA1 plus, that would tell you who should be the one doing that surgery. So to me, I think to call it the OVA suite and this idea of a battery of different tests that are available to help you make clinical decisions that are backed by science and statistics, I think is a long-awaited test that most gynecologists wish that we've had for some time. So to me, that's the biggest difference, but it's really just starting to be released. So I don't think you're going to see a lot of examples of the Overwatch just yet.
Okay. Our next question before we wrap up is wondering, can patients request that their doctors order either of these testing measures?
And they should.
I imagine that maybe we're
absolutely. And if you look at what Dr. Reilly mentioned early on, particularly for Overwatch, Overwatch beside the biomarker, it have a 2 important feature for women. And one of them is age, and second one is the menopause status. And what it means is each individual test come out, it's personalized test. It calculates into your biomarker, but also your age and your menopause status. So individual patient request the test will be provided a personalized score. Each of those personalized scores are coming with a corresponding negative predictive values, allow the clinician evaluate together with entire clinical assessment, including ultrasound as well as any patient family history. So it's absolutely something that many clinicians really encourage their patient to consider this test, particularly when they initially indicated indeterminate or benign.
Great. And I'll go ahead and advance to our next slide because that plays into our last question, is wondering how the attendees can connect with our panelists, Dr. Sea, Dr. Reilly, Dr. Twiggs. Outside of the webinar, our Aspira support email is there, but if any of the panelists have anything additional to add to answer that question, feel free.
Yeah, I think that one of the things that we have with our sales force, which we didn't talk about today, is our peer-to-peer consultation. Right. So if you're a clinician, you order the test and you're unsure exactly how to use the test, you talk to the sales rep and he gets a hold of either Dr. Dutton or myself, and we'll get back with you with 24 hours to help you understand if there's any questions. So that's a that's a service that that Aspira has done for the last 3 or 4 years to further the correct utilization of our tests. And so that's available through the rep. But I think you have the email here. You could email me anytime if you want to talk about a patient. I'm happy to do it. That's part of my responsibility.
Hey.
If you email me, I'll give you Dr. Twiggs' phone number. So.
I don't know how many people are on tonight, but
We all have Dr. Twiggs on speed dial.
Well, thank you all so much for your attendance, and thank you so much to all of our presenters for a fantastic presentation. This recording will be available and will likely be posted at some point in the future on our website for others to see it if they weren't able to attend this evening. Hope everyone has a wonderful evening.
Great.
Thank you.
Good, everyone.